Rustin Becker. I'm Executive Vice President, Oversee Operations with Erdman. Very much looking forward to having this panel discussion today. And before we dive into the discussion, given the kind of variety of backgrounds that you're going to see in a minute here, the variety of different organizations, wanted to give each of the panelists an opportunity to kind of introduce themselves so you get to know them a little bit better, and then also provide kind of a very high-level overview of their organization in case you aren't intimately familiar with it. So I'll go ahead and start with you, David.
Okay, thanks. So I've been doing the healthcare piece for a little over 4 years. Prior to that, doing a lot of corporate real estate for financial services, high tech. So I'm kind of a corporate real estate guy, and I've learned a ton just in the last day or so in healthcare. It makes me change my whole way of thinking on some of our topics today after hearing some of these other discussions. Catholic Health's been around about 20 years. Went from a holding company to an operating company, conglomeration of a lot of sisters of charities, healthcare systems around the country. We're in 19 states, about 100 hospitals, 95,000 employees, about 50 million square feet of leased and owned properties. So it's a pretty good sized system. Still, it could be plus or minus. We're still figuring out there's leases in drawers some places, and we really do own that, because we've done a lot of acquisitions over the last 3 years, which is almost double our size. And with that comes a lot of due diligence to see what they really own and lease.
Okay. Hi, my name is Dave Kistel. I am with Lee Health. I'm the Vice President of Facilities and Support Services. We are located between Tampa and Naples. Matter of fact, if you look at your book next year, Naples, Florida, we're about 30 miles north of this hotel. We do have a new facility. We call it a bedless hospital under construction, and it's going to finish up right around the time I think the conference is next year. So I talked to Michael. We're going to try to arrange a tour for those that are interested. It's really a innovative facility. We have approximately just under 1,600 licensed beds. We like to say that Fort Myers treats the newlywed or the nearly dead. If you ever are in an airport and you see a line of wheelchairs, it's probably at the gate that's going to Fort Myers. We are very, very busy. We're a seasonal, much like Palm Springs. So we have a real challenge. Our population doubles 4 or 5 months of the year. We're also seeing a huge demographic shift. People 65 and over, 10,000 people a day turning 65. Florida now has just surpassed New York. We are the 3rd most populous state in the country. We have 22 million full-time residents. They're expecting in 10 years we'll have 28 million, and that doesn't include the winter residents. So we have quite a challenge down there, and we'll be talking a little bit about that today.
Derek? Hi, I'm Derek Watson. I thank you, Healthcare Facilities and Hannah, for inviting us. I think we have a great panel today. I have the privilege of being the Senior Director of Planning, Design, Construction, and Sustainability for a children's health organization in Dallas, Children's Health System of Texas. We're about a 3 million square foot, 47 outpatient, 3 tertiary and quaternary care hospital system. We have just about 550 beds. It's a non-for-profit system. We see a lot of different things. One of the things that's unique for us is we see about 170,000 kids through the ED on an annual basis. We're probably one of the highest ED hospitals for children in the nation. And we're also, if you look at some statistics in Texas, 1 out of 9 children in the U.S. live in Texas. So we have a lot of kids, and it's growing exponentially. So we're the number 2 populous state to Florida, unbeknownst to California, I believe. Great. Thank you for having us.
So I think you've heard a lot last night and even this morning about all the variety of different things that are creating uncertainty in the healthcare environment today. And our thought wasn't, as part of a panel discussion, to really focus on what those types of uncertainty are, because I think we have a fairly good perspective on what those might be in terms of healthcare policy, the influence of consumerism, changing utilization patterns with population health. Instead, what we want to do is ask some questions to think about different aspects are being incorporated into the planning process with each of these different organizations. And as we open it up for discussion for each of the panelists. We also want to kind of open it up for discussion as a group. So where other people in the audience have a perspective from your own organization or want, kind of to dig a little deeper in the question that we're asking, please, kind of volunteer to do that as we kind of come out of each of the individual questions. And to kind of kick it off, what I thought we'd start with is really, given the uncertainty, how has your planning process evolved or responded to incorporate operational improvement methodologies like Lean in terms of how you're thinking about longer range facility programming and planning needs? And I thought I'd start that with you, Dave.
Okay. Several years ago, we created a 10-year master plan. It included about $1.2 billion worth of facility improvements. One of the challenges we had is that we didn't want to plan or build based on how we were doing business then. We wanted to look forward and how we were going to build in the future. We also had challenges with the fact that our population doubles during the wintertime. And we knew that the problem was just not the acute care hospital. We knew that we had access problems that drove people to the ER. We also knew that we had an elderly population who were not being discharged to home, but were waiting for a nursing home or rehab space. So instead of designing in silos, we brought a team together and really looked at how the integrated platform of care needed to work in our community. We brought post-acute care. We brought in our general pediatric physicians, our primary care docs. We also brought in the healthcare team, and we created a lean planning approach. And there's a lot of fancy names out there, but really it's all about getting the right people at the table and integrating thoughts before you start drawing. And that took us about 6 to 9 months. We brought people in. We really started to recreate the processes of how we are going to provide care in the future. And that changed then how we were going to design the facilities. If you've never done that, I would certainly suggest it strongly, because the outcome was really somewhat revolutionary from what we had been doing. And like most health systems, we're all in silos, and it got us out of a silo, and it really began looking at the entire care process. We also knew that we were going to go from a fee-for-service reimbursement structure to a performance or value-based, and we needed to rechange the way we were thinking about things and how we took care of patients. So it dramatically changed our thought process, and we had great input by our staff, our community, and one of the outcomes of that planning is a facility in South Lee County, just north of Naples. It's we call it a bedless hospital. It's 162,000 square foot. It has everything in it but a hospital bed. The citizenry came to us and said, though we would feel more comfortable having a hospital bed, we understand that you cannot design and build that today because you don't have certificate of need approval. So what they came to us about is said, every time you talk about a hospital, we think of a sick person. We want to have a place that is part of our community that we can go to, and we think about it as a place of health. So part of this facility has a large embedded what's called a healthy lifestyle center. And it really is to begin looking at the health of this population, bringing on teams of people and coaches to help them begin looking at changing the way they're living, eating, exercising, and trying to be proactive. At the same time, we do have the repair shop medicine. We do have a surgery center. We do have a walk-in emergency room, we have the radiology and so forth. So anyway, this facility now is going to be completed in the fall of 2018, and we're going to open that up. And we're using a lot of technology. We will be tracking, the patients will be on a single medical record system, their visits, their diagnostics, their labs and everything. They will provide all that information. We're going to have a technology lab where they can buy different technology, their medical records, they can track that. The people have told us that they want to track their health just like they do their retirement program, and they want to see changes with the activity they put in. So anyway, it's an experiment. It was an operational transformation the way we developed it. And so anyway, we're going to unveil that in November, and hopefully some of you, if you're here next year, will be able to see that in Naples.
Derek or David, any thoughts you want to add
So,
to that concept?
Yeah, I've been at Children's Health in Dallas about 3 years. Previous to that, I was at Adventist Healthcare in Maryland and also Children's National in DC. And planning is always one of the toughest things. The environment today, as we know, and I think a couple speakers before have hit on it, not knowing what, we're 65% Medicaid. We're a safety net hospital. Most of the children's hospitals in the country are in a lot of safety net positions where they're taking care of the children of the cities or counties. And we've really been watching margins decrease over the past 5 or 6 years at a very high rate, which is very concerning with what's going on in Washington right now. We just don't know what the outcome's going to be. But we have started looking at lean processing in everything we do. We just kicked off a peri-op, a second floor renovation project for us, but it's basically will be a 130,000 square foot renovation of all of our peri-op services. And we've brought in a very high-tech architecture firm that's going to be modeling the workflow and the path of work by putting RFID chips in on our badges and tracking everybody that's going in and out of the OR. EVS staff, dietary staff, physicians, anesthesiologists, nursing staff. We want to see where they're going and where they're coming and going to be able to streamline those processes, because every time we turn an OR, put someone else in, we can generate a little bit more revenue. And that's been one area. We've gotten very strategic over the past year and a half. We've got a lot of good strategy. We've hired a chief of strategy about a year and a half ago, and we're getting some really good, here's what we're going to go do, now execute it, versus kind of updating the facilities without really this has a ROI or this really is what needs to be done. We've really started looking at data. The system put in a very complex analytical knowledge base about 2 years ago. We're really starting to see revenue cycle counts that are giving us feedback on why we should go spend money in certain areas of the hospital. Those are things that we're really starting to see. And then just trying to capture for us more commercially insured patients. Every one commercially insured patient counts for about 20 of Medicaid patients for us.
Great. David, any additional thoughts before I open up to the group?
Yeah, this has certainly been an area of challenge for us, especially because of the rapid growth and going again from a holding to an operating company. So what we've been able to do through our leadership is make sure everybody's on the same page and looking at the hospital administration, the physician groups, finance groups, the strategy groups, and then looking at everything we own and lease and how well we're utilizing it, and come up with a plan. Look at the gaps. Is it ambulatory? Do we need more employed physicians, more specialties and that kind of stuff? Where should it go? Kind of the location analytics. And then mirror all that up to the financial feasibility of that. Do we have money to do these things? Do we need to go into third-party space? Do we have some of our own space? So we've kind of been master planning all that and looking at it both short-term and long-term. So we're really deep into that with all these acquisitions, and it's really been good so far. So the future will hopefully tell us a lot more.
And I would challenge it. Who struggles with capital planning right now? Who has a really robust 10 or 15-year capital plan in their system?
The key is robust.
Yeah, and flexible.
Yeah.
And that's what we've used to seeing over the past 10 or 15 years is, you had mentioned a 10-year, $1.2 billion. I got there 3 years ago, and we had $1.5 billion on the table, but a lot of it didn't make sense. It just, Psychiatry, for one thing, behavioral health is a big need for the U.S., but it doesn't make any money, and there's no downstream money. So you've really got to figure out how you tackle those problems. And I think for healthcare institutions, that's one of the biggest things we're going to be struggling with over the next 10 years, especially with CMS and not knowing how they're treating the actual inspections of hospitals, because the behavioral health component is very pricey when it comes to renovating a room to meet all the needs.
Yeah, one of the things that we have seen is that because of our elderly population, and that's will be 65% of our treatment. When we're building new hospital beds, generally you're building 200 beds, 12 to 15%, depending on your market, will be ICU beds. We're over 20% now. And so everybody's market shift, but we're seeing with the new construction just a higher percentage of those ICU beds. The other thing that hampers us is that with that elderly patient coming in, we're also seeing chronic diseases. We're also seeing dialysis needs. Mm-hmm. So as we're building these new beds, we're also really expanding our dialysis platform, because people that are coming in, especially the elderly population, are a lot sicker and require a lot more services. And that's changed our calculation and our percentages as we plan the next 10 years.
So any thoughts from the larger group here in terms of how you're leveraging operational modeling in a more significant way than you perhaps have historically in terms of your planning process right now? I think we've fed everyone too much lunch.
You just have
They're asleep.
Yeah.
They might be asleep.
All right. So capital emerged through that discussion kind of repeatedly in terms of long-range capital planning, different types of capital. Kind of curious, with the range of different capital sources that are available right now, how are you guys kind of looking at the different trade-offs as part of the planning process, targeting different types of capital strategy relative to the planning that you're putting together? And maybe start that one with you, David.
capital. Well, where's Don at from Kaiser? He seems to have plenty for everybody. So, and our group's obviously a not-for-profit as well, and I chatted with them a little bit afterwards, but that's just amazing and good for them. We struggle with that, like a lot of not-for-profits, and we get some from our foundations and philanthropy and all that. We take it off of EBITDA, NOI, and try to use that and dole it out to our markets and our divisions. But we got to look at when we're in a growth strategy, we don't have the money, do we leverage third-party capital? Do you get more bonds, when you already have some of that stuff going on? We've done a recent, very large couple monetizations because we own such a huge percentage of our portfolio, and they were all non-core assets, not the hospitals or anything. So we're able to use some of that and do some lease back. But when you have a lot of deferred maintenance, what gets the grease is going to be inpatient and that kind of stuff, rightfully so. So it's been a huge challenge for us on how to do that. We've leveraged third party, we've monetized, and then we take what we can get in operations, and EBITDA's improved, thankfully, but I don't know if we'll ever get to the Kaiser model. That's just amazing. I was going to ask out there, anybody else have a Kaiser, plenty of money, Kaiser Googles and stuff that they can just spend with? I was just amazed when I heard that. Nobody else has an abundance? Okay.
Yeah, I think they figured that out because their health insurance plan, right? And their goal is to keep people out of the hospital, no surgeries, but they have to do that in a consumer-centric way.
So Derek, how's your organization looking at the different types of capital trade-offs and as part of your planning process?
So we just went through our 2018 process, and it's a very interesting process to sit in the back and watch. There's a lot of pull and tug. In a lot of children's hospitals, for instance, our physicians come from a academic teaching system, so they have needs that they expect us to kind of come up with and deal with. For the past 2 years, we've been adjusting from prior bad practices that were a lot of capital was doled out, and we're trying to catch up with that. But right now, we're working on a depreciation model. Okay. It's really what depreciation we have. We've got some bonds that come up, I think, in the next 3 or 4 years to get those off the books. But we're really trying to focus on what Medicaid's going to do to us or for us, and then also working on a depreciation model of we've got X million dollars, what can we go spend that on and get the best possible return? I've got buildings that are 1962 through 2008. So fortunately, the organization is wise enough. They give me about $4.5–5 million a year for just infrastructure projects, and we've made a big play for that. Every year at budget time, it comes up. Can we reduce that? Yes, we can. But here's your trade-off. You're going to have to give up something. And for some reason, administration really doesn't like sewer leaks in the ORs or in patient rooms. They get really upset about those things. So we always try to remind them about the problems or opportunities we've had during the course of the year.
Dave, any thoughts on how Lee is looking at the different trade-offs on types of capital?
Well, we employ our IT folks to use ransomware. It's actually worked very nicely. Just kidding. We tell them that for as many IT people as we have, they should figure out a way to find this money. But so, that's always a challenge. So when we did our 10-year capital budget, that was laid in with the financial plan. And really what happens is, in our circumstances, that there's a percentage of money that we count on from the community on different fundraising and donations. The majority of it is cash flow. So we have to return a set bottom line in order to create the cash to support these projects. What really happens in our circumstance, the amount of capital then for other types of things goes way down. So when you have this major capital planning go on, just general upkeep of existing facilities, that starts slowing down. Some of these nice-to-do projects start slowing down. And that's always a challenge because you're spending on these new projects, but we don't have the ability. So we probably reduce by half what we normally spend on our routine capital replacements. So that's a challenge. I don't know if other folks have that same situation. Then when you go into a big capital plan like that, you have to reduce. So we do that. And then our CFO watches it very closely because in the event there is a shift, I mean, we're pretty much, if you look at Medicare and Medicaid, we're pretty much federal government paid. So anytime there is an impact to Medicare or Medicaid, and usually it's taking money away, it sends shivers through our organization. We're seeing a much reduced number of people that are under private insurance, and the rest, because we're a community health system, is basically we just write off. So that's something that we have to curtail, and we watch every year. There are certain projects, other than the major projects that have been placed under construction and moving forward, some projects may get deferred. And every year we look at that.
So Derek, you mentioned, I think in your earlier comments, how your organization is particularly sensitive to shifts in public health policy, reimbursement, CHIP funds, those types of things. Given the level of uncertainty around that, how is your organization trying to approach planning right now and have a high degree of confidence in the plans you're laying out?
I think the high degree of confidence is probably ambiguous. We've started a health plan about 2 years ago. We finally saw the first round of actual positive returns on that this past quarter. The CHIP program, I think you mentioned, that's been very challenging. We don't know if that's going to be around. That was a huge supplemental payment that we received in October of this year. We really ramped up a program and a process to go after what Kaiser's done so well with population health about 4 years ago, and we staffed it way up, and we kind of figured out that wasn't necessarily the right way to go. We have a very large Spanish population, and the comorbidity, diabetes and asthma in that group population is exponentially rising. We're not getting the education to them. I think that was one of the tools that we heard earlier today. We've got to educate the population. But the problem is they're not getting educated. So the children are not getting the information they need or the care they need, which is just becoming a cycle. And we're expecting a very large 20 to 25% growth in Texas and North Texas over the next 5 years of continued growth in the Spanish population, which we've got to find a way to educate and keep those three, diabetes and asthma, are the two leading causes for frequent flyers in our EDs right now.
So with that growth, what's your payer mix going to look like before or after the?
So our payer mix right now is about 63 to 68% Medicaid. About 8 to 9% of it is commercially insured, and some just don't have anything. So I mentioned earlier the commercial insurance, one commercially insured patient accounts for 20 Medicaid patients. One commercially insured patient counts for about 50 uninsured or non-insured. And we have a lot of kids that come through our ED, like I said, about 165, 170,000 present visits a year. And we're trying to do a lot of things in the market, but it's an education thing. We have partnered with Dallas ISD, Independent School District. We have nurses in every school now, 280 schools. Garland has ISD, and we have other systems. We're doing a lot of virtual health now. We have a virtual health machine in almost every school now so that they're able to converse with a physician. We've done a lot of virtual health with other participating hospitals across the state of Texas, Oklahoma, and Arkansas. So we're trying to find the avenues, but I think that the biggest thing is we've got to get the education out to help with lowering these common illnesses that are really somewhat preventable. Not everybody with diabetes is, but a lot of them are brought on because of lifestyle.
Dave, any thoughts from your organization? You know, you're particularly sensitive to Medicare.
Yeah. So for us to survive, obviously, it's going to have to shift to outpatient. So we have pretty much aggressively the last few years and stepped into the outpatient arena. We have to find more revenue in order to support our mission. The other challenge is that we're finding we have a population of physicians who are at retirement age. They are not successfully able to recruit this new young physician corps coming out. In most cases, they're not necessarily interested in the entrepreneurial model and working for 20 years and never seeing their wives and to buy into this physician. So we're seeing that model disappear. So we've had to enter into the market. We're doing extensive recruiting to bring physicians into the organization. It's not that we want to compete with some of our physicians. They're just not able to support the volume in our community. So that has been a change in our structure, and as far from a facility standpoint, has led us to a lot of outpatient type of facilities. One of the challenges we've had is that we've jumped out there and we have created a lot of outpatient sites. They're not necessarily integrated into a model. And so one of our challenges over the next 5 years is geographically to begin taking these physician groups and start putting them in a larger model where there's health and wellness activity, there are diagnostics and lab, and then there are physicians. So that's another model that we're doing, and the one that we're doing in South Lee County is a model like that. So we're seeing a dramatic change in the amount of revenue we're bringing in now is coming in from outpatient.
David, any additional?
Yeah,
thoughts on
we
that?
focused on a lot of ambulatory as well. And also over the last 2 years done some huge cost cutting from an operating expenses, and I mean just into the millions and hundreds of millions. It's been really good, but you can't cut your way to margin. Mm-hmm. And so we have some organic growth. We've also done the acquisitions. We've done JVs. The other thing we've done is spun off some non-profitable lines of business like research and different things that was part of it. It's almost like you can't do everything, and getting back to our core business. So it's added up to really help, but we're definitely concerned like everybody else because our payer mix is such that we rely on a lot of the government programs and trying to build that into the model.
So there's been a lot of discussion around the kind of shift towards population health, what that ultimately is going to mean in terms of, either decreased length of stay, decreased inpatient utilization patterns, better management around use of emergency departments, other types of high-end services. To what extent are you seeing that, in your markets, in your organization today, and how are you planning around that longer range in terms of the way you're looking at the capital investments and what you anticipate might be utilization 5, 10, or 15 years from now? And maybe I'll start this one with Dave.
What we're really, somebody talked about this morning is having a foot in two canoes. And that's kind of that's a true statement. I mean, we're being paid in somewhat fee for service, but at the same time, we're moving into a population health, performance-driven healthcare system. I think we all believe that in the future, hospitals are going to be a cost center, and people coming into a hospital are going to be a cost against us. And not sure exactly when that's going to unfold, but there will be larger incentives to keep people out of the hospital. And I think we're all trying to move in that direction. At the same time, we are trying to structure our organization. We're already doing a lot of analytics on our sickest patients, chronic diseases, the frequent flyers, and we're starting to put teams together to define how can we help manage that population and keep them from continuous admissions into our hospital. And if you don't know, obviously, if you're a Medicare patient and you're readmitted for the same DRG within 30 days, that's a free patient. And so you also start getting penalties from Medicare. So we are trying to, and we're putting teams together to try to figure out how to manage these very sick patients and begin managing them at home. So we have some very sick CPD patients that we have at home. We're setting up telehealth. We're having nurses go there. Right now it's a cost to us. We believe in the future it's going to be a savings to us. So that's part of our challenge, is to start doing programs and doing things that you're not being paid for, but it's coming at you. The whole idea about this healthy lifestyle, we know it's the right thing to do. We're not being reimbursed right now for that. So we're trying to maintain our business that's making money, but at the same time, we're stepping into this world we believe is where it's going. So.
Right. Derek, any additional thoughts on that? Or?
Well, I think we'll see insurance changing a lot in the next 5 years. I think that this by territory, by state insurance, the lines are going to blur quite a bit. And I think we're going to see you can buy insurance from wherever, which I think is going to help us. But you mentioned we have a lot of frequent flyers, and we have a lot of kids that are really sick. Our ICU population balloons over the winter, and we've already seen more patients in the month of October than we have, almost a 35% increase over last year's. Kind of goes in 3-year cycles. It's kind of weird. You can kind of watch the populations. But a lot of things we're doing with Pop Health, I kind of mentioned earlier, we kind of bloomed up to a very large staff, and we're kind of maybe lost during that process, and we've kind of come back. We do a lot of research with our partners. We have kids that we've just developed a little tab that goes on top of their inhaler, and every time they press it, it sends a signal to us so that we know they're using their inhaler. When they're not using it, mom and dad get a text, and then we do a follow-up call. So that's something we've invented within the research of Children's and Children's Research Institute. A lot of your pumps now are all Bluetooth, and they can connect to a phone. So we can see when, Mark is not either taking his insulin or eating carbs and what he's doing and be monitoring that, and we can look at that over a period of time. And I think that more in-house, in-home technology, we've been looking at and targeting almost a digital monitoring device that you check in every morning. You go up, it takes your temp, your heart rate, blood pressure, tells you where you are, weight, and this is like daily statistics of being able to track this. So we see these kits, I think somebody talked about them earlier, these kits, smartwatches or whatever else they are, where we're gonna physically hand them out. We've been working with Geek Squad to actually put a presence inside Children's Health, inside the hospital, to help parents, but also to be a distributor of these type of devices. So I don't think we know what's coming, and I think that the next 5 years is gonna be pretty exciting.
Yeah, the only thing I'll add is it's much the same thing as both of you have mentioned, really working on, from a population health perspective, less the length of stay, a lot more research, a lot more going to ambulatory. We're doing that as well.
Yeah.
And just one of the gaps, and I don't know about folks in the room, but we have a real mental health crisis going on. It's not seen, it ends up in the hospital ERs, and it ends up in our patient rooms, if you're not a psych hospital. We have a tremendous amount of people who have no place to go, their health declines, they show up at the hospital, and they are really sick people, and they use a lot of our dollars to take care of them. The discouraging thing is that we fix all their physical ailments. We don't fix their mental ailments. We put them back out there, and they're coming back again. So it's an issue. I don't know what the answer is. Somehow we're going to have to deal with it, but we're dealing with that. And of course, it's disruptive to our ED staff, our physicians, and our patient rooms. Now, everybody's market's different, but I suspect everybody in the room probably, to some degree, deals with mental health. And I'd just be, maybe later, if you all have any ideas or thoughts or how you deal, that we fix them, send them out, and then they come back. And it's a burden. There's a lot of money being spent on that. We're not fixing the problem.
We're definitely not. If I can add, we're renovating an ED right now, our ED, and today we have 3 behavioral health rooms. We started with 6 in the new plan. We're up to 12. We don't know what the right number is. We had 15 patients post last Saturday, this past Saturday, and we don't have room for them. We have a 12-bed dedicated unit. We have other beds throughout the house. I've been watching the trend of CVO, constant visual observation, and it seems like every week we're kind of ticking 9, 10, 11. There were 15 on the report that came out this morning. So this is somebody that a resource has got to sit there with that individual 24 hours a day outside of our behavioral health units. And these kids have a lot of time on their hands. One of our other children's hospitals was just telling me that they had just gone through a CMS survey, and their staff was putting on new door hardware. And a kid comes up and says, that's not going to work. And the kid shows him how he's going to strangulate himself, but it was ligature resistant. So these kids have got time on their hands. It's a huge epidemic. I think it's going to be as big or bigger than diabetes in the next 10 years.
Yeah, and this whole OxyContin thing, again, it's terrible. You wouldn't believe the amount of resources that we're dealing with, and it's all age groups. So again, we're dealing with that. I don't know what the answer is, but unfortunately, by default, a hospital is being asked to do a lot of things it was never really set up to do, at least general acute care hospitals. And the funding's not really there for the psych program. So it's certainly an issue we're dealing with. I assume you guys are dealing with that as well.
Yeah, we've got hospitals. I know personally they're closing their psych units because they can't afford the renovation costs related to it. So we're going the wrong way in the spectrum of number of rooms available in the U.S.
So I'll ask one other quick question, because kind of interesting listening to the conversation. Thoughts here where you don't maybe have enough space, or maybe you don't have enough space in the right space to address what your needs are. But at the same time, we're also in an environment where we're trying to reduce compressed costs, hopefully maybe reduce overall footprints. as you look at your portfolios, and each of you have some fairly large portfolios, are you finding you have excess or underutilized space? And if so, how are you trying to, think about that or incorporate that into your planning? Or are you guys finding you're really kind of maxed out, leveraging everything you have full tilt? And I'll start that with David here.
Yeah, we have both. I was just curious, how many out there, show of hands, have underutilized or vacant space? I would imagine it's, even if you're in a growth mode. That's something we've been looking at the last year or so and walking really every inch of every space. And that's a lot because we have over 2,000 leases, over 800 buildings. And some of them are converted houses that are MOBs and the doctor shows up 2 times a week, grossly underutilized, but it's the market, sometimes it's rural. So we've been trying to think, how can we, and even the bed towers, we've like a vacant wing or a vacant floor, and if we know the chance of us growing and the inpatient's not there, then how can we repurpose that space to clinics or some other things? And yeah, it's high occupancy, but it's just sitting there, and we're never going to probably grow into it. So can we put clinics or other revenue-producing things in there? So we're working on that pretty hard. And then if we can't find a use for a lease space, for whatever reason, historically they've had it, we've got a number of years left, we'll try to negotiate a term fee to get out of it. We'll try to sublease to mitigate our cost. In all of our leases and stuff we're doing now, you like to do longer term so you can get the capital and the landlord pays a big, nice TI allowance. But that's not working well because we need flexibility. We don't know what we're going to need a year from now, much less 5 and 10 years. So we've been doing shorter terms, ability to renew, contract, terminate, expand. We've been building all that flexibility in too, so we don't get to the position we are today. But we're really focused on revenue generating ideas.
Okay.
So we're in a little bit unique because we just happen to be into a large demographic growth state. We did a review of all of our acute care facilities, and if there was a department in that facility that was not providing direct care or was not supporting direct care, they became targets to move out. And so over the last 5 years, we have pretty much moved those people out of the hospital, and we have repurposed that space to some either direct or supportive of direct patient care. We've had to, and that was the best way to utilize our dollars first. There were a lot of areas adjacent to clinical units that we could build legitimate observation units and so forth, so we did that. The problem we ran into, though, is we have this plan when hurricanes come, is that we become a point where we tell the staff, hey, hurricane's coming, you need to either be on the A team or B team. The A team is providing care during the hurricane. The B team comes in after the hurricane to support that staff so they can go home. This last hurricane we had the A team in, the B team were being evacuated, so they evacuated to the hospital. They brought their families, extended families. They brought their pets. I just couldn't imagine telling you my pet stories. We had pets in the hospital. And the problem was we didn't have soft space anymore. So now we've got to think about this whole hurricane deal. Before we had soft spaces in the hospital and we could use that for these areas for people to come in and support them. And we found out this hurricane, we did such a good job of converting it to usable space for patient care, we didn't have the space. So now we've got another problem. How are we going to deal with that? But it's kind of interesting.
Derek, any final thoughts from you? Or?
It's a problem for us. I think a lot of children's hospitals and a lot of even adult hospitals have been added on and grown organically over the years. We're very inefficient. I think we're inefficient to a grand extreme in Dallas. There are some other hospitals I know that I've toured that have the same inefficiencies, but we have no space, zero, not an inch to give up. I don't have shell space, I don't have soft space. Storage in corridors is a problem. We've got all of the common problems that you're trying to eke out every dollar that you can bring in, and you're not able to necessarily give you the storage spaces or shell spaces that you would want to be able to plan for. So we're landlocked where we are, and we're in a very big building that is very expensive to replace. So Some of the children's hospitals have been successful across the U.S., but a lot of them have just, over time, you just grow them. And 50, 60 years ago, people weren't really thinking about regeneration. Everything we do today, we try to think about how do we regenerate the building.
So we're in several locations in Texas. We'll rent you some space for real cheap.
Okay. Are you in Dallas?
All right, want to check in with the group. Any, got a thought from over there?
Thank you. Kind of struggling a little bit on a theoretical basis. So planning under uncertainty, like the great philosopher Mike Tyson said, all fight plan for good till you get punched in the face. So when we're planning, some of the tools you talked about earlier, we're going through planning, we're talking about lean, which are engineering-based processes, right? So we're going through, for lean, for example, we're driving out waste, we're driving out this, yet uncertainty, that drives out flexibility as well, much like we just talked about your space, you're driving out flexibility. So kind of my thought, listening to Dawn earlier, we don't have the capital yet, but part of what they're doing, I think, which helps with uncertainty, we can't engineer how millennials want to access our space. We have to learn, we have to do lessons learned. So how do we change our planning models where they're less engineering based and more lessons learned, but you don't have the capital, but you can take things and try and fail a little bit and be successful in failing if you would, but then take those lessons learned either in your organization or others. So to me, I'm trying to struggle with that. When you're looking at planning under uncertainty, how do we get less away from the tools we've used, because that's not going to be successful moving forward. So any thoughts on that?
Well, I would tell you that I don't think there's any magic sauce. I just think that, and everybody's market's a little bit different. But we've discussed this, and we've created a strategy, but we also know that we need to revisit it every year. We need to look at real good course correction. I know this morning, I think he was showing that where you're moving like this, but you have to be able to adjust quickly. So we understand that. Like I said, we're putting money into a facility. It's a big ambulatory center, but we're not putting a hospital bed in it. And we are creating an environment, we believe, that should be successful in helping people stay out of the hospital. That's a theory. I don't know. Now, when we built that hospital, or built this facility, I challenged our folks. I said, if you're not successful, we're going to need to add beds down here. So from an engineering standpoint, I said, we need to build this as institutional occupancy, because if we do need to add beds in the future and it's not built as institutional occupancy, we're in trouble. So they went along with that. So again, we got one foot in each canoe. We believe in this, but what if it doesn't work? Yeah, so you do take some risk. And it cost us about $8 million more because of the flood issues in Florida. The finished floor of a hospital was 3 foot above what a business occupancy would have been. So I brought in $2 million worth of dirt. And then we built a central energy plant in that. So it was about $8 to $10 million.
Because you had to get out of the 500-year floodplain.
We did, but at the same time, if we did have to add beds, if this didn't work and we still needed beds, now I can add a tower tied into this facility, and it's all institutional occupancy. So you get into these very difficult decisions, and that's the decision we made. So we'll see. I hope we don't have to build those beds, but if we do, somebody's going to be very happy they spent that extra money.
Anna, do we have time for one more?
Yeah, I think we're out of time overall, but if it's okay,
Yeah,
Hannah,
no,
we'll take
we are.
one more. 2 minutes? Would be great.
Gentleman had. Yeah.
Are any of you making money in your ambulatory services?
I can answer that quickly. No.
I think that's like trying to figure out if GE's making money. It's kind of gray. We say we are, but then if you look at where the physicians that we hire these physicians in there, they're not making money. So
And ours is market specific, sometimes no, sometimes yes. And in the case when it's been long time no, we've cut them loose. Because they just kept being a drag and there was no upside. So it's a little bit of both.
We really focus on the downstream. Mentioned psych has no downstream. It's a
Yeah.
huge necessity,
measure
but it's
that?
got no surgery, it's got no downstream to it. A lot of our ambulatory, and we just went through this exercise with strategy because we had several programs that were begging to expand because their waiting room and their wait time is extended over several months before someone can get an appointment, but we're losing money on every one of them. And last time I checked in finance, you can't do more of something and to make money. It just doesn't work. So we went very strategically towards the services that were making money. We're expanding those, and that's where we're, so it's gray, but it's a loss leader almost like you would have at a supermarket. You have to do it. I mean, we're quaternary care, a safety net for the city of Dallas. I mean, we have to provide these services, and a lot of them don't make money, but a lot of them downstream have a downstream revenue that then ties to it. And we really hadn't been that smart about looking at those two. So today we're looking at them completely independent, and then how do they tie back together? A lot of data.